Welcome everyone to this sub-module explaining the mechanisms through which the social determinants of health influence health outcomes. You have already had the privilege to meet my colleague, Dr. Arjuman Siddiqui, and a few words about myself. I'm Dr. Silvia Stringhini, and I am an associate professor at the School of Population and Public Health at the University of British Columbia. And I'm also an investigator of the Edwin Leong Center for Healthy Aging at UBC. So what are the learning objectives for this class? I hope that by the end of this submodule, you'll be able to identify and describe key theoretical frameworks used to explain how social determinants influence health, explain how upstream social determinants impact health outcomes, analyze hypothetical mechanisms linking social conditions to intermediate factors to biological processes and then to health inequities, discuss how social determinants interact at different levels to shape health trajectories across the life course. So I would like to start this by giving you a few seconds, to think about how do we explain inequalities in health. I like to do this exercise with my classes and my students, and to build a word cloud. Of course, we won't be able to do a live word cloud today, but I encourage you to think about that, and which is the first words that comes to your mind when trying to think about what explains inequalities in health. Here this is the slide, one of the recent slides I had in one of my classes. You can see words such as environment, access, income, social determinants, lifestyle. Of course, every class has a different set of words, but generally they repeat themselves, and this is quite a clear representation of what we are going to discuss during this submodule. So first of all, let's talk about the socio-ecological model for explaining the social inequalities and the link between social determinants and health outcomes. You have probably seen this wheel of influence and as in classes about the determinants of health, and what explains social determinants of health outcomes is generally what explains it, what are the determinants of health, similar to the determinants of health. So in this framework, health is influenced by factors operating at multiple interconnected levels, going from societal factors that we may sometimes call distal, meaning that they are farther away and beyond individual control. Among these distal determinants, we generally include factors such as the global ecosystem, climate change, policy, inequalities, structural racism, or colonialism, other historical factors. And then moving towards the individual, we have more and more proximal determinants from the intermediate determinants such as community, neighborhood, school, workplaces, cultural context, interpersonal factors such as social support, family, and peers, going to more individual level behaviors such as smoking, physical activity, and so on. All of these factors have to have an influence on biological parameters and processes to impact health and differences in health, and we will discuss this a little bit more in further down in the presentation. I just wanted to introduce also a different framework, which is that comparing social inequalities in health as being either driven by social selection or by social causation. These two theories present themselves as opposing, while probably both of them are at play. Social selection poses that ill health causes individuals to be in a disadvantaged socioeconomic conditions, while the social causation explanation poses that disadvantaged socioeconomic conditions are influence themselves the ill health. The argument beyond the social selection explanation is that people suffer from ill health in the first place, and then that drives the socioeconomic disadvantage they are in. So the differences in diseases we see are the product of the fact that, and the link with socioeconomic conditions is related to the ill health coming in the first place. For example, this illness may come from a disability or demotion that would then cause a decline in socioeconomic conditions. While there is some evidence to support this explanation, for example, we clearly in partially ill health or illness may cause more disadvantaged socioeconomic conditions. Data generally shows that the impact of ill health on downward mobility is very slight and tends to be limited to certain sexes and age groups. In most cases, social disadvantage causes ill health and not the other way around. So for this class, we will just adopt a social causation framework, knowing that there is a little bit of reverse causation, and we will probably discuss that more in the methods module. So assuming that knowing that we take a social causation framework and going back to the social ecological model, I just wanted to show you which are currently the major mechanisms as understood as linking social determinants of health and socioeconomic disadvantage to adverse health outcomes. And these can be classified as environmental exposures, such as exposure to pollution, environmental factors at the neighborhood level, or living and working conditions, psychosocial exposure, such as cognitive and emotional support, social relationships, exposure to stress or exposure to discrimination and trauma, behavioral exposures such as smoking, diet and physical activity, drug and alcohol use, and access to and use of healthcare. All of these factors have an impact on biological processes to then derive differences in health outcomes. For each of these factors, I will try to present some possible examples. And I will start from environmental factors and social inequalities in health. We know that there are inequalities in health risk related to ambient air quality, for example. There are inequalities in environmental risks associated with housing and residential location, and there are inequalities in working environment and work-related health risks. This graph shows the concentration of PM2.5 at place of residence by neighborhood characteristics, and we have different neighborhood characteristics here. The proportion of people in a manual class occupation, the proportion of people with income below the median, or for example, the proportion of people with primary education only. And what we can see is that with the increase in disadvantage, we have an increase in exposure to PM2.5 for this population. Another example here, again, discussing a pollutant such as a nitrogen dioxide in Swedish children now, and in this paper they compared the exposure to the place of residence and exposure at school in different income quantiles, in different income levels, and we see that children living in poor neighborhoods have higher exposure to NO2 at school and at the place of residence. And then finally, again, one other example is related to housing conditions, knowing that there are, of course, I could spend 3 days discussing social differences in environmental exposures. But here, for example, we can see the self-reported health in relation with housing problems by income group. So in this study, they looked at the number of reported household issues, such as mold growth, bad indoor air quality, or cold, for example, in winter, by income of the residents, and plotted it against the proportion of people reporting poor self-rated health. And as we can see here, is that at all income level, people with a higher number of problems in the household had a higher frequency of poor health, self-rated health, but that the proportion is much higher among participants with low income. If we move now to psychosocial exposures, this is a very interesting study published in Science, and they showed how the number of stressful life events by a socioeconomic indicator, in this case, the years of education. And as you can see here, for example, something that is incredible even is that if we compare the frequency of people ever having a child die, this frequency was 11% in those with a low education versus 1.4% among those with a high educational level. So people with low education are more likely to suffer from a variety of personal stressors. But what is interesting, and you can see in the bottom figure, is that although the number of stressful life events is related to several diseases, the relationship may depend by the genotype of a given gene, the 5-HT gene, which is implicated in serotonin response. In this figure, we see that the number of stressful life events is highly related to the probability of major depressive disorders, but that this is much higher among those with a specific genotype of this gene. If we think about psychosocial factors at the workplace, this is another example comparing the incidence of cardiovascular diseases among 4 groups of individuals in relation to a measure of stress in the workplace, which is job strain. And in this case, we can divide participants into those with low strain, which means a low demand on the workplace and a high control on the time and flexibility to perform these demands, and those with a high strain, which on the contrary have a very high job demand but very low control and flexibility in performing their tasks. And what we can see here is that people with high job strain have higher incidence of cardiovascular diseases than as compared with those with low job strain, those who have a sort of a passive work situation with low demand and high control, and those with a active situation with a high demand and high control. In general, psychosocial factors are related to health inequities because we observe inequalities in work-related stresses, inequalities in personal levels of stress, as we have seen in the previous slide. And then something I'm not presenting here, there are also strong inequalities in social relationships and support. Discussing specifically health behaviors now and behavioral factors in general, there are also very large social inequalities in the lifestyles and behaviors, such as smoking, physical activity, diet quality, and addiction and abuse of substances. Health behaviors and lifestyles are generally very large contributors of the link between the social determinants and health outcomes. Of course, in relation to the fact that they are also very much patterned by all of the other more distal factors that we have discussed previously. As an example, this study shows the trend in the percentage of current smoking among people with 18 years or older by educational level. This is US data, and we see also the trends in the prevalence of smoking, which have decreased enormously, like halved in participants who were college graduates, but have decreased of much lower percent among high school graduates, meaning that inequalities in the proportion in the frequency of smoking are higher in the 2000s than in the 80s. And this is clearly the pattern of smoking is a very large contributor of inequalities in health. If we now discuss access to care in relation to socioeconomic conditions, these two graphs show on the left-hand side the breast cancer incidence rate in relation to income and divided between by race, divided by white and Black women, and in the right-hand side, we have breast cancer mortality. What is very striking to see here is that the incidence of breast cancer is actually higher among white women than Black women, and it follows a reverse social pattern with highly educated women having a higher incidence of breast cancer, and the more disadvantaged women having a lower incidence, while on the right-hand side, we see the mortality, and the pattern is actually reversed, knowing that women with a higher education have a lower mortality, and those with higher rates of poverty have a lower mortality too from breast cancer. So despite the fact that socioeconomic disadvantaged women have higher incidence, they also have lower mortality. And this can be explained by increased by the use of screening, disease stage diagnosis, and lifestyle factors. And then, as I discussed previously, all of these factors have to have a biological impact in order to be able to translate into differences in health. This is just one example of the association between socioeconomic disadvantage and two of stress hormones, where we can see that people with disadvantaged socioeconomic conditions have higher urine concentration of these stress hormones, and we will have a specific sub-modules talking about the biological embedding of social determinants of health. But I just wanted to mention here, because we are talking about mechanisms, that inequalities in biological factors are largely a consequence of environmental, psychosocial, and behavioral factors, and that yes, what we said, that the social environment needs to be biologically embedded to get under the skin and have an impact on health. We have discussed the different mechanisms linking the social determinants of health to health outcomes, but a very important concept that we need to introduce in this framework is the life course approach. The life course approach is the idea through which the social determinants of health and all of the associated exposures cumulate across the life course and to impact at the outcomes, namely all of the experiences that happen from preconception to and progressively into old age contribute to the different trajectories and the different health outcomes that we observe between individuals and populations. So here in this graph, what you will see in this figure, you will see one of the most commonly used frameworks for a life course approach, that is the impact of different factors on trajectories of health outcomes across the life course. Here we have on the y-axis health and functional capacity, and then age, starting from preconception, and then we have drawn three progressive trajectories of building health and decline of three hypothetical people. And we have here, for example, the first part of life where we build health and capacity up to a maximum attained level of health, and then health progressively starts to decline. And we have these three hypothetical people that have a variety of exposures, making their trajectories very different. And then, as we can see, originating differences in health and aging. If we take the example of cardiovascular diseases, for example, into the life course perspective, what we can see here is that, for example, at birth, intrauterine conditions influence weight at birth, and then this has an impact on atherosclerosis. Then going forward into childhood, education and the environment in childhood influence some of these behaviors, some important behaviors such as smoking or physical activity that have themselves an impact on atherosclerosis. Then income and working conditions in adulthood have an impact on work-related stress, which has an impact on cardiovascular disease. Going into old age, where income and wealth have an impact, for example, on access to care, then impacting reduced function. So cumulatively, but also interactively across the life course, the different exposures have an impact at different stages of disease development. There are different life course models that have been developed and are currently used in epidemiology. The first is called the sensitive period model. These are conceptual models, but then they can be translated into different ways in which we operationalize them in our quantitative data analysis. The sensitive period model postulates that it is exposures, for example, to adverse socioeconomic conditions or social determinants of health at specific points across the life course that are particularly sensitive, that can alter permanently our biological system, and then impact health at later stages directly. So, for example, there may be some sensitive or critical period in infancy, let's say at birth, or we talk about this first 1,000 days, or for example, in the transition into adolescence, or when people finish their studies and enter into the workforce. So at repeated stages across the life course, there may be some sensitive periods in which exposures to adverse social determinants of health and their associated exposure has a permanent physiological impact on our systems, affecting health for decades to come. The accumulation model is more similar to the pathway, to the figure that we have just observed, where and it postulates that is accumulation of exposures across the life course that creates differences in chronic diseases, health, aging later in life. Then the pathway model stipulates that certain exposures in specific periods influence exposures in other periods that themselves have then an impact on health later in life. And finally, the social mobility model postulates that it is exposure to adverse socioeconomic circumstances, for example, a socioeconomic disadvantage early in life that has an impact to socioeconomic disadvantage later in life, and it is this socioeconomic disadvantage later in life that itself impacts health and chronic diseases and aging later in life. So what explains these social inequalities in health? What explains the link between social determinants of health and health outcomes or aging and across the life course? It is very difficult to give a comprehensive answer to these questions because, for example, as we have seen and as we know, social inequalities in health vary by health outcome. What we can see here is the median mortality relative risk in men across a large variety of health outcomes. And as we can see here, for example, health outcomes that are related to smoking have a much larger sort of like a socioeconomic relative risk than health outcomes that are less related to common risk factors. So there are very large differences in depend on the health outcome on how social determinants of health impact health. The impact of the social determinants of health on health also varies by country. This is another example showing the percent of the population reporting fair or poor health across very different countries, and it shows this percent by income tertile, where we have the top, the middle, or the bottom income that tertile that we can see in the darker colors of red. And as we can see, there is first of all a very large variation in the percent of people reporting poor health, but also the disparities within the population are very different depending on the country. For example, Chile has a very large social gradient in this perception of poor health, and other countries such as Japan or Switzerland have a smaller variation within their population. Finally, inequalities in health also vary over time, and the impact of the social determinants of health on health outcomes also varies over time. We have two examples here of these variations over time. And for example, this graph represents the annual household income, excluding the top 1%, over time in the United States. And as we can see, these inequalities in income have progressed over time. And then, as we can see on the right inside, the inequality that we observe within quantiles of income for the same health outcome, which was year, age, and death, have also incredibly increased between the cohort born in 1933 and the cohort that was born in 1960, with a very large, very large differences between the poorest and the wealthier quantile between these two cohorts. So differences again over time. The heterogeneity of social differences in health makes it difficult to actually give an answer to what explains inequalities in health and what explains the impact of the social determinants of health on health, because these, whatever explanation we can find is only valid in that specific context, in that specific time, or for that specific outcome being investigated. So socioeconomic health differentials are dynamic across cause, place, and time. The particular pattern on how socioeconomic health differentials are expressed in a population, that is their magnitude, cause-specific composition, and trends over time, is sensitive to interdependencies between disease environment, social differences between countries, and changing social conditions within countries. So one theory that is able to probably sort of like take this all together is the fundamental cause theory. This theory postulates that health disparities persist over time because some groups consistently have more access to flexible resources such as money, knowledge, power, or have larger or more impactful social networks. These resources enable people to avoid the risks and adopt protective strategies as soon as health threats change, making these elites or people who have these resources always on top of having the best health outcomes, depending on how they change over time and depending on the context. This theory, the fundamental causes theory, shifts to the focus to upstream factors and help explain why, for example, new technology often increase rather than reduce inequalities. So which are the take-home messages for this very dense and intense session? As we have seen, health inequalities are driven by social determinants that operate across multiple levels at the individual, interpersonal, and community and societal level, and are best understood through integrated frameworks such as the socio-ecological model and the life course perspective. We have also discussed the fact that the social causation is the dominant explanation at the time for the impact of social determinants on health outcomes, and it is supported by longitudinal evidence. Then we have also seen that material condition, environmental exposure, psychosocial stress, behaviors, and unequal access to care are key pathways linking social disadvantage to health outcomes, and that these mechanisms co-occur and compound one another and over time. So we have also seen that health inequalities vary by outcome, context, and time, and must be understood in a dynamic, context-specific way. A life course lens reveals how disadvantage accumulate or is impacted by exposure happening all across the life course from conception. And then something that we have discussed or suggested at different points in this session is the importance of intersectionality that is crucial in understanding health disparities, and we will have a more specific section on intersectionality in the following module. And thanks a lot for your attention.